for that. And I'm not sure I'm a really excellent speaker, but I do have a large part of my practice for a long time has been Parkinson's in particular and movement disorders, so Parkinson's and Huntington's. And I used to be a CL psychiatrist at the University of Alberta, so I did CL Psych for about 10 years before I did my Geri Psych exam in 2016. And so I presently work doing just Geri Psych on the inpatient side and outpatient. We're very lucky here in Edmonton. We have a 150-bed inpatient secure facility for Geri Psych. So we've got a very rich patient population and exposure to. But my niche interest has always been movement disorders. And so, as was mentioned, I've been their consulting psychiatrist since about 2008. So what I'm going to talk about today is Parkinson's and Lewy body dementia. So those are kind of the topics for today. As I mentioned before, I may have bitten off a little bit more than I can chew with sort of the amount of material. So we'll kind of go through. What I would like is that if there's any kind of questions throughout or any comments, I'm happy to be interrupted. I don't want this to be just strictly a didactic session, but by the same token, I do think there's quite a bit of information that we can cover. So it's very nice to meet all of you, and I'm super excited to meet you all across the country. So I will try and share my screen here, and we'll see if we can get going. So. All right, can everybody see that?
Yep.
Yeah, okay. So basically sort of the topic that I want to focus on is just sort of the idea of understanding Parkinson's and Lewy body, but focusing a little bit on the motor stuff. But I think mostly what I'd like to do is focus on the non-motor symptom pathology, so the ability to recognize that. And then we'll talk about a couple of different strategies potentially for treating, and hopefully this will be a practical session in the context as well of getting to know just some different approaches to managing this as well. All right, so the first thing is I have no conflict of interest to declare. Nobody's interested in me, and I'm not interested in anybody else either. No pharma, no nothing. So this is just straight up from the heart. So. All right, so the objectives for today are review epidemiology and clinical manifestations of PD and Lewy body, recognize non-motor symptoms of Parkinson's and Lewy body, and then we'll discuss some approaches to the management of non-motor symptom pathology in particular in Parkinson's and Lewy body as well. So this is just a little introduction here. This was the original essay on the shaking palsy by James Parkinson, written in 1817. So Parkinson's as a disease entity and certainly as a description with regards to a neurological disorder has been present for a long, long time. Idiopathic Parkinson's, so we're going to focus on that versus sort of drug-induced Parkinsonism or any other facets from that perspective, is again a neurodegenerative syndrome. And again, most people recognize it based on its motor symptom pathology. So again, the motor syndrome, just a quick overview: rigidity, bradykinesia, tremor, postural instability. So prevalence is around 315 per 100,000 in North America. Why it's of relevance to us is the fact that it is an age-related disorder for the most part. And we're looking at percentages of probably over 1% of the patient population over the age of 60 with Parkinson's. And as patients get older, obviously that number is going to keep going up as well. So one of the things that a lot of people don't necessarily know about is that Parkinson's in and of itself can come in a couple of different sort of clinical varieties. Probably the most common one that people are familiar with is a tremor dominant. And so that's where the patient presents largely with the characteristic pill rolling tremor. But patients can also present with an akinetic rigid kind of a picture where there is no tremor, or tremor is very limited, and they're really more so that bradykinetic kind of a picture. And then also some patients in particular with a Parkinson's plus syndrome can present with postural instability and gait difficulty as being the predominant symptoms at the time of presentation. So again, just a quick little overview. Motor symptoms, again, we know are caused by degeneration of dopamine neurons in the substantia nigra, in particular the pars compacta. The degeneration is caused by a buildup of alpha-synuclein and the generation of Lewy bodies that lead to essentially cell death. And one of the things that's really interesting and I think important is that when patients have the onset of motor symptoms, they already represent roughly about a 50% loss of dopaminergic neurons in their motor pathways, okay? So by the time the clinical syndrome presents, we've already had substantial neurodegeneration. And that's important because we have a lot of symptoms that actually exist in patients prior to their motor manifestation. So this little slide here is just a way that I've conceptualized for myself what some of the different symptoms, or at least clinical presentations, are based on the disease stage for patients with Parkinson's. So many of them will have in that pre-motor phase, so before their actual diagnosis by a neurologist, patients may present with non-specific anxiety symptoms, non-specific depressive symptoms, and this can be roughly about 2 to 4 years prior to the onset of motor symptoms. Patients can present with anosmia or hyposmia, and that can be 10 to 15 years, sometimes a little bit longer prior to the symptoms. REM sleep behavior disorder, again, can precede motor symptoms by about 10 to 15 years. We might see apathy, and then a lot of patients will also describe cognitive changes as well. And these changes are often related to speed of information processing, as well as complex attention. So the big challenge for us in geriatric psychiatry is that a lot of these initial premotor symptoms are things that we can see in just sort of what we would consider to be a bread and butter anxiety or depression or later onset. And one of the things that's going to be important for you is, as you screen for some of these patients, is to potentially look at some of these other symptom clusters, anosmia, hyposmia, REM sleep behavior disorder in particular, as being some potential manifestations of a separate process and not just anxiety, depression. So then we move over clinically into the motor phase. And so again, the motor phase is typically identified in most patients as that initial tremor and slowing or bradykinesia. For idiopathic Parkinson's, it's typically unilateral, and then it progresses to bilateral. And so that's different from our drug-induced Parkinsonism, which often, if it's present, will present as bilateral or kind of system-wide. Once then we move into what I call the treatment phase. So this is when patients are exposed to dopaminergic medications. Then patients will often have on phenomenon and off phenomenon, or what we refer to as motor fluctuations. So this is response to medication and then lack of response to medication. During the treatment phase, we're also going to potentially see impulse control disorders. We're going to potentially see dopamine dysregulation syndrome, and we're also going to see anxiety, dysphoria, and depression, both as a component of a progression of illness, as well as a manifestation of motor fluctuations as well. Then as we look into sort of the more progressive phase of the Parkinson's itself, patients will present more with freezing, they'll present more with gait instability, we'll start to see more cognitive changes, a component of which will be anxiety, a component of which will be hallucinations. And there's a particular behavior that patients will show, which is something called punding, which is almost like a BPSD-like phenomenon, in particular in Parkinson's, that is basically related to compulsive hobbying, or the progression of, typically it's fixations with dismantling things. So it was originally described in methamphetamine users, but these are patients that will do things like take apart the stove, take apart the lawnmower, they'll take apart their vehicle. For women, they'll have a compulsive hobbying kind of pattern, could be related to shopping, could be related to any particular hobby they have. And so that's a particular phenomenon that occurs. And then we have our end stage component where we're looking more at a overall neurological collapse and then focusing more on end of life care than we are on management of motor or non-motor symptoms. So one of the things that I think is helpful, just as a bit of a reminder, is just to kind of go through, in particular, as we talk about treatment, from the PD motor side of things is just kind of the different medications that are utilized for the treatment of the motor symptoms in Parkinson's. So we have the particular dopamine related agents themselves. So these are medications that are dopaminergic, but then they also have a decarboxylase inhibitor, which prevents the breakdown of the dopamine as it crosses the blood-brain barrier. So the two medications that are used here in Canada are Sinemet, so levodopa-carbidopa, and the other one that is available as well is one by the name of Prolopa. So it's levodopa still with a different decarboxylase inhibitor, which is called benserazide. Then we have catechol O-methyltransferase inhibitors, which are added then to reduce the uptake of dopamine within the brain itself. So this is entacapone or Comtan. So the thought is it's going to elongate or prolong the effect of the Sinemet itself. And there is one combination medication that has levodopa, carbidopa, and entacapone, which is called Stalevo. Then we have a separate group that are related to dopamine agonism. So these are the dopamine agonists. So we have Pramipex or Mirapex, Ropinirole or Requip, and then Retagatine or Nupro are the dopamine agonists that are available on the market. Some of you may have had exposure to these outside of Parkinson's in sleep-related disorders. Some are used in restless leg syndromes and other things like that. Then we have another class, the monoamine oxidase inhibitors. So of these, the most common present one that is used is Rasagiline or Azilect. But some patients are also exposed to Selegiline. So this is either MSAM or Eldepril, and this is also a pill or it comes in a patch form as well. We'll still see some neurologists that will prescribe anticholinergics. So in the same way that we would use benztropine or otherwise in our patients with extrapyramidal side effects secondary to antipsychotic exposure, some neurologists will still use anticholinergics as the primary therapy. The biggest one that they use is trihexyphenidyl, or Artane is the name for it. And then the last one that you're likely going to potentially see in your patients is a medication by the name of amantadine. So amantadine works through the NMDA receptor. Amantadine is used for all kinds of things, including treating flu-like symptoms. It's primarily used in patients for managing disabling dyskinesias, which again are abnormal movements that result from hyperdopaminergic states related to levodopa replacement. Okay, so just a quick little overview of kind of the different things you're going to see potentially. So what is of importance, I would say, more so from my perspective as the consulting psychiatrist, is related to the fact that in Parkinson's, it is essentially the quintessential neuropsychiatric disorder. And as such, we have a very broad set of symptoms that fit into what we call the non-motor symptoms of Parkinson's. So when we break down the neuropsychiatric side of things, we've got apathy, depression, anxiety, psychosis, impulse control disorders, dopamine dysregulation syndrome, and punding. From an autonomic perspective, we have GI side effects, predominantly constipation being the issue, genital urinary, urgency, frequency, neurogenic bladder, and then adrenergic dysfunction as well, so orthostatic hypotension and postural instability. Then we have sleep-related phenomenon, of which REM sleep behavior disorder is the main one. You can have fatigue as an independent non-motor symptom cluster. You can have pain as an independent non-motor symptom cluster. And then we have the cognitive piece as well, which we'll talk a little bit more when we look at Lewy body phenomenon as well. So the reason, in my opinion, why the non-motor symptom clusters are important for you guys to be aware of and also to be able to have a little bit of an approach to management is that many patients will actually report their non-motor symptoms as being the biggest predictor of their quality of life, okay? So in close to 50% of drug-naive Parkinson's disease patients, they will relate severe to very severe burden of non-motor symptoms. So this is before they're ever even managed with a dopaminergic agent. There was a study that was done that looked at kind of 227 newly referred PD patients. They were followed over a couple of years. The non-motor symptom burden, more than the motor score, predicted quality of life. And in particular, when they looked at mood, apathy, sleep, fatigue, attention, and memory, these were also most significantly associated with quality of life. And then within our patient population as well, The non-motor symptoms also predict caregiver distress and earlier institutionalization. So it's a very important set of symptoms that I think that historically have not been managed well in a neurology clinic, but they are being managed significantly better now, I think, in movement disorders, multidisciplinary programs. So when we look at our approach to treating non-motor symptoms, despite the fact that over 50% of patients that are drug naive are going to have a severe to very, very severe burden, despite the fact that probably 80% of patients with Parkinson's will at some point have disabling non-motor symptoms, we really do not have a huge evidence base as far as our approach or treatments. And so what we're going to do, hopefully today, is just kind of go through what the evidence shows, but then also go through a little bit of a practical approach to things as well. So there was a big update on the treatment of non-motor symptoms in Parkinson's disease put out by the Movement Disorder Society. This is actually a really good paper if anybody's interested in this area and further reading. So in 2019, February, they essentially identified no high-quality randomized controlled trials for anxiety or REM sleep disorder, and then very limited studies overall. So recommendations in general are very limited. So a lot of what we're going to talk about today is just kind of a clinical approach, as well as how would you decide what to do. So we're going to start with depression. So when we look at depression in Parkinson's disease, probably about 17% of patients with Parkinson's will meet the criteria for major depressive disorder, and probably closer to 35 to 40% will at least have depressive symptoms that are functionally impairing in Parkinson's. So one of the things that we always want to look at is sort of what are some of the validated tools that we can look at for detecting depression. So in Parkinson's in particular, what's shown to be validated is the GDS, so short version 15, Beck Depression Inventory, as well as the Montgomery-Åsberg Depression Rating Scale. Having said that, you could still use the PHQ-9. You could potentially, a lot of the studies still use the HAM-D as well. But again, when you're looking to detect, just like you would in any kind of medical comorbidity, really you're wanting to focus on more of those guilt symptoms, hopelessness, helplessness. A lot of the psychomotor stuff and changes in sleep and patterns that way are not going to be discernible because they may be related to the underlying Parkinson's itself. So when we look at treatment of depression in Parkinson's, the most common medications that are used are the SSRIs and the SNRIs, I would say. The SSRIs in general have an aggregate effect on depressive symptoms. One of the things that's important to know is that all SSRIs have about an 8 to 10% risk of tremor-inducing phenomenon. So this can be very difficult, in particular in your elderly patients who present with more of those prodromal anxiety depressive symptoms. You put them on a medication, they develop a tremor, right? So is it a medication-related phenomenon, or are you unmasking an underlying neurodegenerative disorder? Okay, when we look at the evidence base itself, so the Movement Disorder Society puts out, as far as their guidelines or recommendations, what is considered to be efficacious or clinically useful is venlafaxine, so an SNRI, and then also pramipexole, okay? So a dopamine agonist medication for depression. So I would argue that most of us would not use a dopamine agonist as our first line of treatment for patients with depression and Parkinson's, because it has significant other potential side effects, including impulse control disorders. But it does reflect the fact that a component of depression in Parkinson's is related to their overall motor symptom pathology. So the thought is that improve motor symptoms, then your improved mood as well. What has been deemed to be likely efficacious or possibly useful are actually two tricyclics, so dizipramine and nortriptyline. Also likely efficacious is CBT, and then insufficient evidence, but possibly useful, are actually SSRIs, SNRIs other than venlafaxine, and then also repetitive transcranial magnetic stimulation. Okay. So when I look at depression itself, how do I decide? I decide in very many ways the same way I would for some of my other patients. I essentially want to look at interventions that may target multiple symptoms or interventions, again, that are going to be the least harmful. So the SNRI you might choose if the patient also has a potential comorbid neuropathic pain syndrome. Lots of patients with Parkinson's will have a central pain-like phenomenon that is a separate non-motor symptom phenomenon. So citalopram, escitalopram, again, fewer drug-drug interactions, but we need to be careful with prolonged QTC. And the reason we need to be aware of that in Parkinson's is that a lot of patients are on other QTC prolonging agents as well as part of their treatment. Again, mirtazapine, you might target for insomnia, GI sensitivity, weight loss, reduced appetite. Bupropion, more apathy, psychomotor symptoms, younger patients to reduce sexual side effects. If the patient has associated impulse control problems, bupropion may be helpful to reduce the expression of that. And then tricyclics, again, if you have patients with neuropathic pain, headaches, and then also within the context of treatment-resistant syndromes. Okay. CBT has been looked at and has been validated with regards to its use in Parkinson's. Probably the biggest article that was done on it was American Journal of Psychiatry in 2011. It basically looked at CBT as being very effective, but it was tailored, shall we say, to the PD population. So focused a lot on anxiety, a lot on sleep, a lot on exercise, and it also had a caregiver component to it as well, which I think made the intervention quite successful. So the challenge with CBT and Parkinson's is that you need to have a practitioner that is aware of the illness. And the reason that I say that is because a lot of the symptoms can shift in Parkinson's based on their overall motor symptoms. And so strategies or techniques that need to be implemented need to take into consideration the fluctuating course of the underlying illness and not just the psychological phenomenon of depression. So just this past year in the American Journal of Geriatric Psychiatry, this algorithm was published, and I would say it is a reasonable algorithm if you're looking for a starting place to look at. And so what we're basically looking at is patients with PD with depression. Tier 1 interventions will be monotherapy with an SSRI, SNRI, mirtazapine, bupropion, TCA. They've included vortioxetine, plus or minus behavioral activation, and plus or minus CBT. If your patient fails a couple of these monotherapy trials, just like in other areas that we're treating, you're going to look at potential dual antidepressant therapy. If psychosis, agitation, or mania is present, you might look at monotherapy plus quetiapine. If there are motor fluctuations present, you might look at pramipexole or the dopamine agonist, as I mentioned, does have first-line evidence for it. And then if they have anxiety or REM sleep behavior disorder as a comorbid phenomenon, you might be looking at the addition of benzodiazepines carefully. And then as we kind of go through the different tiers, you're going to be looking again at adding other things like lamotrigine, brain stimulation, so RTMS as well as ECT. I would argue that ECT is an absolutely essential treatment in Parkinson's disease, in particular for patients with psychotic levels of depression or severe depression. They respond very well to ECT, and it also helps their motor fluctuations and motor symptoms as well. And then sort of the last one that they talk about here, tier 4, is monoamine oxidase inhibitors. So either selegiline or some of the ones that we know about, phenelzine, nardil, tranylcypromine, or parnate as well. So the next kind of non-motor symptom cluster is anxiety. Anxiety, I would say, is going to be one of the more challenging symptoms for you to manage in patients with Parkinson's, in particular as their illness progresses. So anxiety can be one of the most disabling symptoms of Parkinson's. Often it's related to the unpredictable nature of the PD motor symptoms. And so what I see typically clinically is through the roof anxiety when patients are in an off motor state. So often it is related to the motor fluctuations in Parkinson's. And so what is very useful in these patients is to get them to do an anxiety diary and get them to time their symptoms based on when they take their Parkinson's medications. And that often will give you a lot of insight into what is going on, and often will give you a bit of an idea as to how best to approach treating this, okay? So patients may also have a generalized form of anxiety. They may also have panic attacks, and a subset of patients are going to present with a social phobia-like phenomenon, which again is sometimes related to their tremor and them being self-conscious about it, and at other times is actually related to their inability to process cognitive stimuli in the same way. So they become overwhelmed in certain environments that are a bit more crowded, novel situations, and things like that. So when I look at treating anxiety, how do I decide, the best approach to things? So there's going to be patient factors. So we're going to be looking at age, history of pre-existing anxiety, right? Did they have something that was being treated before? Their history of prior benzo exposure, substance use, medical comorbidities, and medications. We'll look at illness factors as well. So cognition, motor fluctuations. Do they have dyskinesias? Is this related to falls? Is it related to freezing of gait? And then we'll also look at system factors as well, right? So what community supports are available and what kind of access do they actually have to psychological therapies? So a benzo may still be utilized if the patient has comorbid REM sleep behavior disorder, if there's an associated dystonia, okay, so that sustained muscle cramping because of its muscle relaxant effects. And if there are marked motor fluctuations, a small dose of benzo, longer acting like clonazepam, might help to even out those motor symptom fluctuations. You might choose an SSRI or SNRI if there's more of a generalized anxiety picture, if they have comorbid depression or apathy, comorbid pain, or if they had a pre-existing anxiety disorder already, then you might look at trying to optimize and treat that as well. One of the things that the guidelines do not talk much about at all is the gabapentinoids. So I use a lot of pregabalin in my patient population with Parkinson's, and gabapentin can also be utilized. Again, for patients with a generalized anxiety picture, if they've failed other therapies or pain, pregabalin works very, very well with these patients. And then again, mirtazapine, if it's marked psychological insomnia or psychophysiological insomnia or weight loss. And then if the anxiety is more related to cognition, then a cholinesterase inhibitor would potentially be what you would look at. So this is a very busy slide here with regards to, again, a treatment algorithm related to anxiety. The thing that I want to draw your attention to isn't so much your general approach to anxiety, but I want you to draw your attention to this last little bit here related to what they call a special case. So this is what I would say is anxiety-specific phenomenon in Parkinson's disease, okay? So if their anxiety is related to motor fluctuations, so in other words, they only have anxiety when their Sinemet wears off, or they go into an off motor state, then your approach is going to be to try and optimize the delivery system of their baseline dopaminergic medication. And that would be in conjunction with the neurologist. If it's specifically fear of falling that the patient has, then CBT, PTOT, exposure therapy, that kind of a thing is the approach. If it is cognitive, as I mentioned, you're going to look at a cholinesterase inhibitor as your intervention. And if it's autonomic related, so it's related to changes in blood pressure, in particular hypotension, then you're going to want to focus on that as your intervention, not just adding more of an SSRI, SNRI, or trying to treat it from a psychiatric perspective. Okay, so the next symptom cluster we're going to talk about is apathy. This is my daughter on a day when there's no school and there's no synchronized swimming and her parents are busy and not paying attention to her. Okay, so this is what apathy looks like. So apathy, again, is a phenomenon that can exist in the premotor state. It is a phenomenon that can exist separately as its own non-motor symptom, or it can be a component of cognitive impairment as well. And that's what's important, is to identify, because that allows you to try and look at approaches. So if it's a part of depression, antidepressants. If it's a part of cognition, the cholinesterase inhibitor. If it's a standalone symptom, stimulants may be considered, or modafinil may be considered as well. And if it is related to the motor component of things, again, a dopamine agonist may be helpful as well. And then non-pharmacological approaches, again, are going to be routine structure, exercise, music therapy, occupational therapy, and behavioral activation. Okay. So the next area that we're going to talk about is dopamine dysregulation syndrome or impulse control disorders. So I hope most of you recognize this particular figure. And if not, it's a great movie for you to see. Al Pacino and Scarface. Okay, that's his big mound of cocaine there. When we look at this particular symptom cluster, it's very important to identify that this is largely in Parkinson's patients related to medication side effects. Okay, so dopamine dysregulation syndrome is primarily with levodopa equivalent medications. Okay, and by definition, this is using more levodopa replacement than required for optimal motor management. Okay, so this comes back down to the pharmacokinetics as well as the pharmacodynamic effects of exogenous dopamine in the brain. So when we think about this, when we give a patient Sinemet, you're giving them a pulsatile exogenous release of dopamine. Okay. Like our antipsychotics, okay, we hope that the D2 blocking effect is largely in the mesolimbic pathway. It spills over into motor pathways and otherwise. It's the same thing with levodopa. You want it to be in the motor pathways, but it spills over into the mesolimbic pathways, ventral tegmental area, nucleus accumbens, all about the reward pathway. So dopamine dysregulation syndrome is essentially patients that are addicted to their Sinemet. Okay, so they will pop Sinemet like it's Pez. Okay, and as a result of that, they will often get a euphoric or a hypomanic or manic response to the medication. Okay, we see this primarily in young onset male patients. Okay, so the other one is impulse control disorders, which I think most people have heard about. These are largely related to dopamine agonist medication. So Mirapex or pramipexole, Requip or ropinirole or rotogotine or Nupro. So these are compulsive gambling, hypersexuality, pornography, compulsive shopping, nighttime eating behaviors. Okay, so these are very particular to the dopamine agonist class of medications. Okay, so when we look at the Movement Disorder Society's treatment of dopamine dysregulation syndrome and ICDs, they recommend cognitive behavioral therapy. Okay, cognitive behavioral therapy, in my opinion, does not work for these patients at all. Okay, so when we look at our approach to managing these particular symptoms in patients, the treatment has to be coordinated with the neurologist. Okay, you have to obtain collateral, in particular from family members, as patients will not tell you that they have this particular side effect. You need to assess for safety. And the biggest thing that needs to happen is you need to limit access to medications. Okay, when I first started in the Movement Disorders Clinic back in 2008, it wasn't unusual for a neurologist to prescribe a patient a year's worth of Sinemet. Okay, so if you could imagine how big a jar of Sinemet you'd pick up from the pharmacy, and patients would basically just take it at their own volition. For these patients, you need to limit their access. So we're looking at potentially weekly dispense of medications, blister packs of medications, whatever it is, and then a slow reduction in the dosing of the medication, or trying to reduce sort of that pulsatile treatment schedule that patients are on. And as I mentioned, again, levodopa for dopamine dysregulation and the dopamine agonists for ICDs. And then if we're looking at treatment in and of itself, naloxone, naltrexone, again, this is sort of ancillary from other literature for addictive behaviors. Bupropion, if patients have more hypomanic or manic, quetiapine, clozapine, or divalproex have been shown to be useful. And then if patients have more of a compulsive, again, SSRIs, SNRIs, or quetiapine. And then the big one here is inpatient assessment and treatment for patients that are really, really dysregulated from that perspective. Okay, so the next big symptom cluster is psychosis. So when we're looking at psychosis in Parkinson's disease itself, The largest risk factors are going to be levodopa equivalent dosing per day, dopamine agonist exposure, and then cognitive decline. Okay. So for most of our patients, they need to be on roughly, I would say, over 1,800 milligram equivalents a day of levodopa for us to see more of a psychotic reaction. With dopamine agonists, we can even see it at very low doses that patients will hallucinate and or have delusional ideation. And then obviously with cognitive decline, it'll be a hallmark of that particular presentation will be a psychotic component. So in Parkinson's, like Lewy body, the psychotic symptoms are typically complex visual hallucinations, but many patients will also have a delusional jealousy or Othello syndrome. And often, again, we see this in male patients accusing their spouses of infidelity, and it can be a very significant problem to deal with in patients with Parkinson's. So again, when we look at treatment approach for psychosis in Parkinson's, again, assess for safety. So collateral, again, is a major one we're looking at. We want to eliminate reversible causes. So in the same way you do a delirium workup and or otherwise in your patients, you want to then reduce or optimize the Parkinson's medication contribution, treat cognition if that's a component. Otherwise, we're left with essentially quetiapine or clozapine as being the two antipsychotic medications available here in Canada. And in the US, they also have pimavanserin as being another option there as well. If we look at the actual evidence base, quetiapine is possibly useful with insufficient evidence, and clozapine is clinically useful and does have efficacy. But most of us actually would treat with quetiapine without any hesitation with a good response. And I would say I only have a handful of patients on clozapine. And then likewise, an inpatient assessment and treatment may be required for patients if their psychotic symptoms are severe or if safety concerns are paramount. Okay. So we'll just shift now a little bit to cognition in Parkinson's. Probably the biggest thing that's important is that early cognitive changes are present even in that premotor phase of Parkinson's, again, related to speed of processing and attention as well. Okay. The Lewy body dementias, okay, when we look at them as a group, they comprise both Parkinson's disease dementia as well as dementia with Lewy body. Together, they're the second most common cause of neurodegenerative dementia and represent about 7.5% of all older adults with dementia. Again, the histopathological characterization is Lewy bodies, again, comprised of alpha-synuclein. Okay. So diagnosis, we've got revised criteria that came from 2017. So you need to have cognitive impairment. The cognitive impairment in these patients is largely attention, executive function, as well as visual perceptual or perceptual motor. You then need to have core features. So fluctuating cognition, recurrent visual hallucinations, REM sleep behavior disorder, and then features of spontaneous Parkinsonism. Then you have a number of supportive features, which is the neuroleptic sensitivity, postural instability, recurrent falls, syncope or other transit episodes of unresponsiveness, the autonomic dysfunction, hypersomnia, anosmia, hyposmia, hallucinations and other modalities, delusions, apathy, anxiety, or depression. Okay, so these are all supportive features of which a large number of them are psychiatric symptoms. Okay. We then have some biomarkers that are actually available. So we have reduced dopamine transport in the basal ganglia, which can be done on SPECT, which is a DAT scan, or can be done through PET, which is an F-DOPA scan. There's a very interesting phenomenon that you get abnormal low uptake in myocardial scintigraphy. So this speaks to that autonomic piece in Parkinson's. So you can actually do this particular nuke med scan and make a diagnosis of Lewy body or Parkinson's disease dementia. And then we talked about REM sleep without atonia, in particular on a sleep study. Supportive biomarkers also exist. So relative preservation of medial temporal lobe structures on CT-MRI, generalized low uptake on SPECT or PET. So this is FDG PET with reduced occipital activity. And then also you can get prominent posterior slow wave slowing on EEG as well. So there's quite a few different diagnostic tools that we do have available to us when we're trying to make the diagnosis of a Lewy body dementia. So this is a very busy slide, which again talks a little bit about the differentiation between an Alzheimer's pathology via neuroimaging and a Lewy body or Parkinson's disease phenomenon. And so basically this speaks to amyloid PET and FDG versus dopamine transport PET versus FDG as well. So we won't go through this, but this is actually a pretty good algorithm as you're studying for your exam, in particular, to look at some of the different ways that you might be able to differentiate neurocognitive disorders based on kind of what the modern imaging available is, okay? So some of the other clinical features that might be present in Lewy body is males may have more of a classic picture, whereas females may initially present only with auditory hallucinations. So this is interesting because when we look at our diagnosis of a late onset primary psychotic disorder in females or schizophrenia in females, one of the hallmarks of it is sort of just almost like exclusive positive symptoms and auditory hallucinations. So it may actually be that a subset of what we've historically called late onset schizophrenia may actually be patients that are in that prodromal stage of Lewy body. Okay. Likewise, in the prodromal stage, research groups have identified 3 prodromal stages in Lewy body. So one is cognitive impairment, which is what you would think about normally. Another one is a delirium onset, which is important in your CL patients as well as in your patients that come to your units, in particular with prolonged deliriums or inadequate provoking factors that are found. Many of these patients will go on to manifest a Lewy body picture. And then we also have patients that will have almost exclusively an initial psychiatric presentation with visual hallucinations, Capgras syndrome, which is a major one, systematized delusions, or apathy, anxiety, and depression. Okay, so a couple of particular clinical presentations just to kind of keep in mind as you're working up your patients. Okay, so what I've included in here is again something that you guys can look over. This is an assessment toolkit that was put out by a group in Scotland with regards to being able to identify sort of Lewy body dementia, and it's actually a really nice little checklist that it has here, looking at whether these symptoms are present or not. And so one of the things here, when we look at Lewy body dementia, it gives you the diagnostic criteria, your core clinical features, whether you can get a probable diagnosis with 2 core or 1 core and 1 indicative, possible Lewy body as well. So again, this is a really simple little worksheet to work through. And I would say is actually really quite useful to give you a little bit of a structure in how you approach your patients, in particular history-wise, and gives you a little bit of a tool to implement as well.
Just to interrupt, I think Vincent has a question. Did you
Okay.
want to take that now or wait till
now?
the
Yeah.
No,
Okay.
it's a really quick thing. I just wanted to let you know that we could not see the algorithm you clicked on. Like we only see the PowerPoint.
Okay. All right. I will have to figure that out. Okay. I'm wondering if it's a share screen issue. Okay. So then what I can do is I can send you those links as well. So Catherine, I can send those separately.
Sure.
You can disperse those.
Yes,
That'd be great.
please.
Okay.
Yep.
And then again, from the management side of things for Lewy body, good evidence for cholinesterase inhibitors. So both rivastigmine as well as donepezil. Memantine can be utilized alone or as an add-on as well. When we look at psychosis, again, cholinesterase inhibitor, quetiapine versus clozapine. Mood and anxiety, again, limited data, but we can go back to what we talked about before. And then apathy as well, the cholinesterase inhibitor. And then our REM sleep behavior disorder piece, melatonin plus or minus a combination of clonazepam. Some studies indicate memantine may be useful for sleep as well. Okay, so I'm going to try this again. This is a slide here. So when I do that, does that show up? No?
No.
Would you be willing to share your slides after the fact?
Absolutely.
Or should we? Yeah, okay. Awesome.
Can you see this now?
Yep.
Okay.
Yes.
So this is
good.
a really good management overview, in my opinion, for your patients with Lewy body dementia. So cognitive approach, neuropsychiatric approach, sleep approach, how do you deal with orthostatic hypotension, constipation, urinary dysfunction, all these sorts of things. But probably the biggest thing that I want you guys to look at or focus on this is this particular component here, this slide, is that if you're managing these patients as inpatients and you may have not a ton of neurology support, this gives you a bit of an idea as how you might withdraw certain Parkinson's medications if you felt they were contributing to the overall clinical picture. So anticholinergics first, then amantadine, then MAOIs, then dopamine agonists, then COMT inhibitors, and then levodopa overall dosing. Okay. And all right. So quick summary. Although the most common symptoms of PD are non-motor, the non-motor symptoms are just as important to appreciate and manage. Treatment strategies are available with dealing with most non-motor symptoms, but the evidence is not super robust. So you're going to have to, just like many things, just kind of clinically approach things. And then from the Lewy body side of things as well, I think we're going to see a lot more Lewy body as time goes on. We're going to be able to make this diagnosis, I think, a lot more accurate in our patients as well, and largely because we have a lot more biomarkers available to us with regards to that. And then just kind of a little bit of a management approach as well for patients with Lewy body. So that's all I'm going to talk about formally, and we'll just kind of open it up for a little discussion. And like I said, I'm sorry, that's a lot of information. But hopefully it gives you a little bit of an idea of Parkinson's and Lewy body as well. So
Thank you so much. That was fantastic. I learned so much. I know there's a question in the chat, and I also posed a question as well. Does anybody have any questions they want to ask before we go to the chat? No? Okay. Let's start with Amanda's question. Do you provide patients with specific guidelines on how to chart their anxiety and motor symptoms? For example, do you have a special anxiety diary you provide them?
yeah, so I don't have a special one that I provide, but actually within our movement group though, however, we do have a symptom diary that works really, really well. So it basically looks at timing of dosing of medication, it looks at motor response, and then it looks at the non-motor symptoms as well. And that's an excellent, excellent tool. When they're inpatients on our unit, typically what I do kind of behavior charting and get the nurses to focus specifically on the timing of the behavior itself. And then I often will map it back to sort of when they're getting their medications or not. So, yeah.
Awesome. Is that something you could share with the slides possibly?
Absolutely. Yeah.
So much information, so much content, and so important. Yeah, any other questions anybody wants to say out loud before we
I
move,
had a
perhaps?
quick question.
Yeah.
I was just wondering, it's something I haven't heard discussed so much in psychiatry, but I've heard neurologists talk about the concept of vascular Parkinsonism. And I was just wondering if you could comment on that, Dr. Perez-Parada.
So yeah, so vascular Parkinsonism for the most part is thought to be related again to either a very specific stroke that occurs, or if you've got enough of vascular events within the basal ganglia, and sometimes also within the white matter pathways as well. So these are patients that are going to present with the motor symptoms of Parkinson's, but they're not going to have a ton of the non-motor stuff associated with it, and they're not going to have the ancillary idiopathic Parkinson's symptoms. The reason that it's clinically important is that a lot of those patients do not respond as well to levodopa replacement. And so Sinemet may be utilized as a tool, but often it's not very effective as well. Again, that particular form of Parkinsonism can still present unilaterally, but also bilaterally, but often you're looking at more sort of on imaging, you're going to see more vascular stuff than anything else. So, yeah.
I also have a question. So in treating psychosis, we have the option of cholinesterase inhibitors and quetiapine, clozapine. In your experience, which would you start with a cholinesterase inhibitor? I just wonder about like the onset, how quickly it's going to.
That's a great question. That's a great question. So the biggest thing that I look at is from the psychotic side of things, we look at insight. So does the patient have insight into their hallucinations and what they may mean? And then safety. Okay. So if there's lack of insight or there's safety concerns, then I often will start the antipsychotic right away. I will then, in conjunction, if I do believe it's cognitively based, I will start them on a cholinesterase inhibitor. And then as time goes on, if I can, I'll wean them off the antipsychotic. But realistically, they often end up on both. Yeah.
Thank you. That's helpful.
So we have about 4 minutes left, and I think Amanda has a follow-up question or maybe a new question. Curious about what doses of quetiapine you have found adequate to treat psychosis.
Yeah. So again, it depends on whether the psychosis is cognitively related or the psychosis is PD medication related. So if the psychosis is PD medication related, we may be looking at going upwards of 200 to 300, sometimes 400 milligrams of quetiapine. Again, we're usually younger patient population, and we're usually stuck with kind of the dosing that the neurologist has chosen. When we're looking at it from a cognitive perspective, I would agree with those dosing more so there, probably in that 50 to 100 range. The only thing that I'm doing a little bit more now, Amanda, is I'm using a little bit more of the sustained release quetiapine. So I may choose to do, 50 or 100, dose it at supper time. It then helps with some of the BPSD sleep stuff, but then offers enough of an impact the next day as well. So.
All right, we have 3 minutes left. Any more questions?
I'm interested by the one that you brought up on Cinemet. What's the experience? It tends to be very divided, neurology, psychiatry. So I'm tempted to do it, but as I'm, still supervising, it always ends up being, no, this is neurology, and we don't do that.
So what my hope is as you guys become practicing geriatric psychiatrists, in particular, if you do have an inpatient component to your practice, I would say you have to absolutely be comfortable manipulating some of these medications, okay? And the reason that I say that is that a neurologist will not hesitate for a second to prescribe either quetiapine or an antidepressant or a benzo, or tell you what is right, wrong, or everything else. They'll be able to tell you about management of everything. So in this particular circumstance, in particular, you need to be comfortable, in particular, reducing medications, okay? If it is a new onset Parkinson's and you're not really clear about the diagnosis being idiopathic versus vascular versus being a Parkinson's plus, I would say absolutely consult with your neurology colleagues. And I do think that that's what I would do, absolutely. But once they land on your doorstep and you're managing them because of their behavioral and psychological symptoms or their neuropsychiatric symptoms of Parkinson's, you have to be comfortable fiddling with their meds. Yeah.
All right, so we've got 2 minutes left. I don't know if we're going to get any more questions in.
Yeah. All right. So for if you guys could provide feedback, I know it was a ton of information and a lot of slides, but if you could provide some feedback as to things you liked, things you didn't like. I know it's a big topic and it's a very specific topic, but I do think as geriatric psychiatrists, this is going to be a component of the bread and butter you're going to see. So, okay.
Thank you, George. And I am going to be sending out specific feedback questions to the group. So please stay tuned. And thank you so much. We're going to ask you to come back for 2 sessions next year, I imagine. It was so helpful, so pragmatic, and we really appreciate your time.
All right. And nice to meet everyone.
Okay, bye now.